Good morning, good afternoon, good evening, wherever you are, and welcome to this TechNet webinar. Today, we're happy to welcome Path to discuss findings from a healthcare worker evaluation to the COVID-19 vaccine label. Before I give Allela the floor to introduce you the panelists and the topic, here's some information on the webinar. So you can ask your questions using the Q&A area or the chat box. The team will answer all your questions after the presentation. We are recording the webinar, so we'll share the links of the video as well as the presentation by email with you all, and it will also be shared on TechNet 21. Allela, the floor is yours.
Greetings, everybody, and welcome to this webinar from the Living Labs Path. I'm excited to have you here. So 2020-2021 pandemic has treated us in ways we couldn't imagine. And this particular session themed COVID-19 vaccine label user evaluation will discuss the work that Path Living Labs has engaged to actually support immunization stakeholders and actually support the rollout of immunization of the COVID-19 vaccine. Next slide. So in this session, we will go through the project backgrounds, process, and tools, as well as findings and implications of the user evaluation. We'll also present a quick deep dive into other Living Labs activities, and we shall listen to remarks from a representative from Zambia Ministry of Health over this particular engagement. And as mentioned earlier, there'll also be an open Q&A session. To start us off, I would like to give a chance to our three speakers who have taken their time, next slide, to speak to you from across Zambia and Kenya on the COVID-19 vaccine labeling work. And with that, I'd call Casildah Lumamba to introduce herself, and then she'll call forth Brenda Magula, who will also talk to us about Josephine Simwenga. Casildah.
Thank you, Allela. My name is Casildah Lumamba. I'm a creative designer based in Lusaka, Zambia, Living Labs project. Over to Brenda.
Hello, my name is Brenda Magula. I'm a creative designer with the Living Labs project based in Zambia. So Josephine Simwenga will be joining us in just a bit. She's trying to connect. Over to you, Allela.
Thank you very much. It is great to have you, Casildah, Brenda, and equally to have Josephine join us. And I speaking, I'm Oyugi Allela, a creative designer at Living Labs, Kenya. We'll give short presentations on the subject matter, and the rest of the session is open to question and answer. Please feel free to submit your questions via the chat section and on the webinar, and we'll answer as much as we can after the presentations. So get your questions in, and to note, we would love to hear from you. Next. To briefly state who we are from Path Living Labs, as I've mentioned, and Path Living Labs seeks to accelerate the pace of health innovation by co-creating with users to rapidly design, explore, test, and scale solutions to their long-standing challenges. We were established in 2019, and we are a team of more than 15 plus human-centered design experts based in Kenya and Zambia. We work with healthcare actors to design solutions for a range of healthcare challenges, such as immunization, maternal health, and nutrition. And with the COVID-19 pandemic, we quickly adapted our ways to support our partners in co-creating solutions for pandemic response, as well as the vaccine rollout. We use a methodology called human-centered design, which is a creative approach to problem solving and starts with understanding the people you're designing for and ends with new solutions that are tailor-made specifically to suit their particular needs. Human-centered design is based on engaging deeply with individuals and communities so that you can build deep empathy with the people you're designing for, generate numerous ideas, and then test and iterate prototypes until an acceptable, appropriate, and viable solution is identified. Through using human-centered design, we're able to improve the feasibility, desirability, and programmatic fit for several healthcare solutions. Thus, in supporting immunization to stakeholders. Next. In preparing for the COVID-19 vaccine rollout, the Living Labs initiative in Kenya and Zambia recently conducted a rapid assessment of usability and acceptability of the COVID-19 vaccine labels. Next. This test was able to could support the delivery and acceptability of COVID-19 vaccine based on a need highlighted by the Coalition of Epidemic Preparedness Innovation, that is CEPI, and the World Health Organization, which found that due to the urgent need of access to the vaccine post-approval, there is an urgency for a universal label for the vials and packages to enable mass distribution. The aim, therefore, was to evaluate technologies for the labeling, as well as to access the frontline immunizations providers' perspectives on priority features and requirements that they needed on vaccine labels, as well as perceived advantages and disadvantages of proposed technologies for vaccine labeling. And in addition, we needed to find out the challenges and experiences they are having with current vaccine labels, as well as the knowledge management needed on vaccine potency and safety. Overall, what we were seeking was to develop training programs for healthcare workers on delivery and use of COVID-19 vaccines, as well as inform updates to future labeling designs for batches of the COVID-19 vaccine. We therefore engaged, next, several users. And as I mentioned, we use HCD and we listen to user voices. We engaged 65 users from the two countries, that's Kenya and Zambia, and they were from 28 healthcare facilities. These users were from sites that offered a maximum variation, representing 18 rural facilities, as well as 10 urban facilities. The users also were of varied perspectives, varied skills and roles. For example, we engage EPI logisticians, which is a persons responsible for vaccine distribution, health promotion officers, who are persons who are community advocates on health-related issues such as disease control and management, nurses at facilities that offer the vaccines, as well as facility in charges and MOH stakeholders, that is the Ministry of Health stakeholders. The diversity of our stakeholders certain that the feedback and insights collected from immunization healthcare workers in the development in the final output, that output having been stated earlier being the development of a universal label and the development of training programs for the COVID-19 vaccine, was based explicitly on understanding our users, their tasks, the environments in which they exist, and the labels are driven and refined by a user-centered evaluation, and that the user's voice allots room for iterative development. And finally, these outputs will have addressed the whole user experience and concerns when introduced. Next. So what Living Labs did is, as I mentioned, we've been in existence since 2019. We leveraged on our existing relationships with immunization service providers we've had contact with in the long term. And we call these service providers super users based on our level of engagement. We do trust that our super users are often honest and will tell us if they not like something or not. That level, we have that level of confidence in this numerous number of users that we call super users. So we engage with providers in two phases. And in the first phase, we used the 2 Ds of the HCD process, that is discover, whereby we identify healthcare worker needs and priorities on vaccine labels, and then define, whereby we develop a point of view that is based on identified user needs and insights. So in our phase 1, the discover to define stage, what we did, we held a virtual workshop in Zambia to introduce the COVID label project to the stakeholders in Zambia, and even just highlight the need of user feedback. Secondly, in both countries, we sent out a questionnaire, this being a remote survey in the form of a Google or Microsoft form that was sent to 50+ super users, The samples of standard WHO package and vial samples were embedded in the surveys to actually draw out priority features and requirements on vaccine labeling challenges, and even current experiences with existing labels. This data was collected and processed using Miro platform. And basically, Miro is a virtual collaboration tool, which I would call just a big whiteboard that is accessible online and can be accessed by multiple teams from different places in the world. And in our second and of our phase one, we also developed, from the survey outputs, we also formulated a comprehensive targeted focus group guide, and also developed new sets of mock-up labels that when we went into our phase two, we'll be able to conduct a deep dive of the insight we listened out in phase one, and even the things we felt like there's need to actually know more, to listen to these voices that we sought out to listen to. And at phase two, we went through the discover all the way to design stage, and in particular define what the dream phase and design stage was about. So during the dream phase, we generated multiple ideas with healthcare workers on training requirements or modules for vaccine delivery, on vaccine labeling, and even developed vial prototypes, the kind of vials that best suit the need, the kind of vial packaging and packaging that they felt upon delivery, they will easily understand, and it will actually enable easy allocation of doses to patients. So at the phase two, what we did was we had a focus group discussion, which was virtual and in person, to prioritize the vaccine label elements. We tested various scenarios, co-designed a vaccine label. And in the focus group discussion deep dive, pre-developed vial mockups were developed to evaluate scenarios for vial and vaccine packages, because in the context of expediting mass distribution of the vaccine, it was possible that some vaccine label characteristics will not be established by the time the vial and packages are labeled for use. I'll use an example. There's a possibility of the expiration date not being established on our vials upon delivery because of the possibility of various aspects of the vaccine, such as stability and shelf life, shifting the expiration date. And even another attribute that is often seen in many vaccine vials, the VVM, which is a vaccine vial monitor that allows healthcare workers to know at a glance if a vaccine is safe for administration. It might not have been established because VVM, because of possibilities of mass manufacturing of the VVM. You'll notice that the photo on phase two does not have people in mask or social distancing because it was a photo taken pre-COVID. Next slide, thank you. Thus, to highlight the possibilities of this non-established establishments that I've mentioned, we took up a design challenge that sought to seek how we might, for example, modify training and communication if the VVM and expiry date were not available on the label. Additionally, to look at the acceptability and desirability of the vaccine if expiry dates were handwritten and looked up on a site rather than labeled on the vaccine. If QR codes were established on the labels instead of an expiry date. If, for example, the label stated that the vaccine expires 3 months after the manufacturing date. And these scenarios provided us an opportunity to understand healthcare workers' priorities on label features, as well as foretell their expectations and needs in the likelihood of vaccine delivery, acceptance, and even training. Overall, both phase one and phase two enabled us to understand the key label elements that inform the healthcare worker workflows, including cold chain management, expiry, and training requirements. We further held a series of follow-up interviews post-distribution of the vaccine in the two countries, and I will now hand over to Casildah Lumamba to provide findings and implications of this particular study. Casildah.
Thank you, Allela. Next slide. In both Zambia and Kenya, the insights gathered around priority features were overarching. Our findings indicated that the above details, that's the name of the vaccine vial monitor, dose per vial, number of meals, manufacturer, expiry date, route of administration, batch number or lot number, side effects, and storage needed to be part of the vaccine label, as these would assist the healthcare workers in safe handling and they would feel confident to administer the vaccine. Healthcare workers indicated that if the vaccine vials had these priority features, they would easily identify the vaccines. So during our engagement with them, we learned that currently there are some vaccines such as pentavalent and PCV that have the same vial size and same color of the labels, which makes it hard for them to differentiate, especially for the newly deployed staff. Hence the need for the vaccine labels to be prominently labeled. So healthcare workers indicated that all along they have been trained to look out for these features when they are preparing for their immunization sessions or when they are about to administer a vaccine. So having a vaccine that does not have some of these features or any changes that could be made to their standard operating procedures would need to publicly and officially document it. Next slide. Implications on missing vaccine vial monitor. Respondents from both countries were consistent in stating that both the vaccine vial monitor and the expiry date must be included in the vial labels to ensure that the potency and safety of the vaccine is assured, both to the healthcare workers and also to the clients that are receiving the vaccine. Most of the healthcare workers said they would be skeptical to use a vaccine without the VVM, since having the VVM is an important standard operating procedure for them. Recently, we spoke to 18 healthcare workers in Lusaka, Zambia, to get their views around the rollout of the COVID-19 vaccine. We learned that they have great concerns around the missing VVM and also the manufacturing date, which makes them very uncomfortable to administer the vaccine. In terms of vaccine safety, healthcare workers mentioned that they are currently relying on instructions that they have been given to discard the vaccine after 6 hours. Missing vaccine vial monitor has also led to an increase in vial wastage. Initially, healthcare workers were opening a vial when they have at least 10 clients, which was leading to missed opportunities, as most clients would leave before they had that number that they were looking for. Later on, they were told to open a vial whenever a client comes, and sometimes it takes time for another client or for the next client to come, and they have to discard that vaccine after the 6 hours that they've been instructed to, or at the end of the session, and that has led to increased wastage of vaccine. Next slide. Implications of missing, handwritten, or confusing expiry date. Healthcare workers in both countries indicated that less visible writings on labels is a major source of vaccine administration errors. They said they would not administer a vaccine with missing, handwritten, or confusing expiry date, but try and seek clarity from their supervisors. Although trying to seek clarity from their supervisors would be quite challenging for most of the healthcare workers due to network challenges in the areas where they provide services from, especially when they have gone for outreach activities. And if they are unable to get that clarity on the expiry date, that would result in missed opportunities to vaccinate the clients. Healthcare workers mentioned that if they saw a vaccine without this feature, they would assume it was not done by the manufacturer and it has not been approved for use. The expiry date, according to healthcare workers, is also a standard of operating procedure that healthcare workers always look out for and cannot be omitted, as this can be used to ascertain the safety and potency of the vaccine to prevent them from administering expired or potentially harmful vaccines. Next slide. When asked about the websites, QR codes, and barcodes, healthcare workers indicated that these would only be helpful as secondary source of information on the vaccine or any updates that would have been made about the vaccine, and not as a primary source of information. So to get an in-depth understanding on the access to additional information, we shared a sample vial with the healthcare workers that had the handwritten expiry date. Some healthcare workers were able to use the lot number that was on the vial to check for the expiry date, while some were unable, with most of them saying that they had seen these codes, the barcodes and the QR codes in the current vaccines that they currently use, but they never knew what the purpose of those barcodes or QR codes were. Some cited internet connectivity as challenges and lack of smartphones to scan the barcodes or QR codes. And some healthcare workers considered it as cumbersome and also time consuming, especially if this has to be done at the point of service delivery. And the information also would be untrustworthy because they would not know whether this was really done by the manufacturer. It was indicated that the barcode or QR codes are susceptible to damage when labels wear off and can be limitation for referencing of vaccine viability. And so with this, healthcare workers felt that it was important that the vaccine labels should have all the information that they require to ascertain the safety and potency of the vaccine, to give them all the confidence they need to administer the vaccine. Next slide. So in Kenya, the team held a co-creation session where healthcare workers designed their ideal vaccine label, which included the name of the vaccine, the number of doses contained in each vial, method of administration, the storage conditions, the vaccine vial monitor, a leaflet that would have the details about the vaccine, including the expected side effects of the vaccine, the batch number, the manufacturing date, and also the expiry date. So with this designed vaccine label, the healthcare workers felt that this is what would work out well for them. Next slide. So some of the critical factors that need to be considered for a successful COVID-19 vaccine rollout include the need for a strong government support so that healthcare workers can be helped to adapt to new vaccine introductions with the support of a strong public communication or policy. And that way they would have documentation that supports them that the vaccine they are rolling out or they are administering is an effective vaccine, and their concerns around losing community trust in an event of side effects would be covered. There's also need for compendium of explainers with the expectation that there are different vaccines from different manufacturers that have different handling requirements. It is preferable for healthcare workers that a holistic reference guide for all vaccines is provided to them, or to have explainers for different vaccines to be available during the initial training. And also there's need to adapt the training to their context. The online training developed has good content. We gave them a link where they were able to log in to check out the content for the training, and they said it had good content. However, the online access proved to be a challenge to some of the healthcare workers due to data connectivity and also the cost that may be associated for the healthcare worker to fund themselves to be able to access the online training. Next slide. So we have shared our findings with the Ministries of Health in Kenya and Zambia to help inform COVID-19 vaccine rollout plans. And some of the insights shared have been put into consideration in Zambia. We have also shared results with the immunization community, and there are global discussions around label standardization, which still remains to be seen. And the engagement to date with the national regulatory agencies has not been conclusive. So I will now hand over to Brenda Magula to walk us through the other Living Labs activities. Over to you, Brenda.
Thank you, Casildah. So to walk you through the other Living Labs activities, I'll be talking about the insights that we have gathered with the healthcare workers around the country, that's in Zambia and in Kenya. So the insights are about the views on the rollout of the COVID-19 vaccination. So the healthcare workers stated that it's good that the vaccine has been rolled out because it will help to protect them from the COVID-19 virus. One healthcare worker cited that having been on shift in the outpatient department, which is the hotspot of the infection, the vaccine was a must to have because she could protect herself by having it after being exposed in such an environment. And so she further indicated that they predict the cases of the COVID-19 to go up with the cold season that is slowly approaching here in Zambia. And so they felt that the trainings would be done more especially for the community health based volunteers, because they are the ones who are in direct contact with the community. And so it would be good for them to do the rollout with the training to be done mostly with the community-based volunteers, so as to have easy acceptability of the vaccine, as there are a lot of myths around the COVID-19 vaccine. And so healthcare workers also mentioned that the social media bloggers should desist from showing videos that may affect acceptance of the vaccine, but instead they should send positive messages that would encourage uptake of the vaccine. And so much concentration should be done on the benefits of the vaccine and not on the negatives. So we had a healthcare worker who quoted to say, I got vaccinated because I am a healthcare provider who is at high risk of getting infected with COVID-19, and I want to be an ambassador for other healthcare workers and for my family. Next slide, please. So the other projects that the Living Labs is actively working on is the first one being the co-creation of motivational solutions for frontline immunization healthcare workers. So the challenge around that is that frontline immunization healthcare workers have a demanding job, but often have limited resources and support. This subsequently brings about demotivation, and at the end, it drops the coverage, the immunization coverage rate. So in trying to mitigate this, the creative designers have designed, built, and tested prototypes together with the healthcare workers, as they are better placed to produce solutions that meet their needs. So in turn, this helps them to learn, improve, and achieve increased uptake of the immunization services. So an example that I would give around the prototypes that we developed was around the community vaccine transport concept, which we called the COVAT. This was developed in Zambia. So this concept focused on engaging local leaders to negotiate for transport fares on behalf of the healthcare workers to the community members. So the challenge was that healthcare workers are normally charged exorbitant price when they go to approach the transport providers in the area, just in case a motorbike breaks down, they have to look for a private transport to take them for outreach services. And in that case, they are charged exorbitant prices. So we prototyped a solution where the community could be engaged in sourcing for transport for the healthcare workers. The third project that the Living Labs is embarking on is the usability test of the COVID-19 paper-based information system. So the challenge around that is that managing progress towards the 90% immunization target is difficult when providers don't know how many children are coming for vaccination daily and do not have easy tools for reminding caregivers of scheduled immunization dates. So having a tracking tool for clients is vital as it assists to plan for vaccine stock and also just to offer quality care to the clients. So the approach taken in this instance was engaging healthcare workers to design, prototype, and test a client scheduling application, which would let healthcare workers make appointments with caregivers and trace clients. This would result in proper decision-making for planning of vaccines, and also it would help to decongest the health facilities when mothers are taking their children for immunization. Next slide. Okay, so that was all about the activities in the Living Labs. So to take us through the perspective of the COVID-19 vaccine labeling work, I would like to introduce Mrs. Josephine Simwenga, who is the Chief Expanded Program for Immunization Officer at the Zambia Ministry of Health. She has been in this position for 12 years. She holds a master's degree in public health, and she holds another master's degree in gender, and also a bachelor's degree in art of nursing. Over to you, Mrs. Simwenga.
Thank you very much, Brenda. Thank you very much, Tim. Unfortunately, I'm in the field where I am, internet is on and off, but I hope I will be able to share with you one or two insights. Hello?
Yes, we can hear you.
Okay, am I audible?
Yes, you are. Go ahead.
Okay. Okay, fine. As Ministry of Health, to start with, on behalf of the EPI team, I would say I think we've been quite grateful with the PATH Living Labs, because from inception, we've been together in the field trying to get insights of the 4Ds for these health workers. And then maybe just to zero down on the activity of branding of the COVID-19 vaccine. At least our health workers were given an opportunity to try and submit their views. And most of the issues that were submitted, as highlighted by Casildah, we saw them actually appear on the vaccine itself. The only thing is it was the issue of the VVM and manufacturing date. These were mentioned even from the beginning. So in a snapshot, in the gatherings that we are getting, we are yet to do a comprehensive evaluation and supervision so that we can come up with a consolidated or written report to that effect. But the few views that we are getting from the health workers who are in our tier 1 and the others is the issue of the concern of the VVM not being there on the vaccine. And when you try to find out how that could lead to low uptake, And the answers that they're giving us is that according to our policy, all our vaccines, if anything, all our vaccines have come with the VVMs of late. From the time the VVM issue policy has been in the country. So to say our routine vaccines have a VVM tag on it, and this somehow brought uncertainties within these health workers. And then some of them were even questioning the issue of not the manufacturing date not appearing on the vial, because they were saying if the manufacturing date is not there, how sure are we that the vaccine was manufactured 6 months ago or 3 months ago? So what we did prior to that, as national level, we had known those things were going to be there. So we did include them in our training package. Unfortunately, when we're doing our introduction, we couldn't target everyone because our trainings are usually cascade trainings. And this time around, we had started with the health workers who are going to be vaccinators. So this is the time now when we are trying to roll out these trainings to other health workers. And we are also working towards even improving our messaging. Right now, there's a team of national level supervisors who are out in the field to try and gather more information, and together with the information that has been gathered by the Living Labs team to see how we could improve this in our next training. I think unless maybe Brenda, there's something that you want to add on, or Casildah?
Nothing from my end. Well elaborated, Mrs. Simwenga. I would now hand
and if
over.
anything, that's. Oh, Brenda, sorry. I just wanted to say, actually, that's why I'm saying I'm in a place where my internet is on and off, because I'm in the northwestern province of Zambia as part of the team that is on the supportive supervision visit.
Thank you, Mrs. Simwenga. Just to add that Mrs. Simwenga has been also engaged during the time when we were collecting the insights from the healthcare workers about the COVID-19 vaccine labeling. We were working closely with her. Thank you for that. I will hand over back to Allela.
Thank you very much, Linda, Brenda, and Mrs. Josephine. I'm very curious, Alex, do you have any questions?
Yes, we do have some questions. So let me start. Okay, so thanks for the interesting information. Have you thought of the vaccine manufacturers' perspectives? How are you going to communicate with the manufacturers? How to trade off the tailored approach with the manufacturer's capacity for more than 200 countries? Thank you.
Thank you very much for that particular question. I will request Brian Taliesin to kindly give us an answer on this. Thank you, Brian.
Thank you, Allela, and thank you all for all the presentations, and especially Mrs. Simwenga. I greatly appreciate your partnership over the last several decades on the EPI program in Zambia and globally with the BID initiative before that. With the one of the great things that I've appreciated about the expanded program on immunization is that they've done a good job on standardizing how training happens for new vaccine introductions over the years. And so that's a spot of what you were sort of seeing on the vaccine labels of here's a sort of a standardized approach of what we were doing. And so all of the, with those 60 plus healthcare workers that had been part of this evaluation, they've probably collectively delivered over millions of vaccines in their during their job experience. And so we did sort of want to bring that voice back to the manufacturers, and I've been doing that as part of the ACT Accelerator efforts and presented to the manufacturer SWAT team of these items. And in general, there's spots of where they just didn't know enough yet, or the vaccine vial monitor for the particular cold chain requirements hadn't been produced yet. And so in general, those items are sort of on the roadmap for the manufacturers to basically get back to the standard labels that the healthcare workers are expecting. So initially, it is a lot of change management right now, as it was expressed for the training changes in Zambia. And hopefully we're going to see in the future batches that we'll know more on the expiry date, as well as having the VVMs in place. Over.
Thank you very much, Brian, for that concrete explanation. I'm very curious, Alex, any other question?
Yes, there are some other questions, but I would like also to remind every participant, if you have more questions, please don't hesitate to use the chat room for the Q&A question and answer area. As a next question, as the vaccines have started to be distributed, how have the nurses responded to the lack of VVM?
So thank you very much for that. I'll take on that on the Kenyan side, and I believe Brenda or Casildah will answer the same for Zambia. So in Kenya, the vaccines arrived without a VVM, and post interviews from once the vaccines were delivered, healthcare workers were initially hesitant actually to receive them because they consider having a VVM on a vial as a standard of practice. But this is a case whereby you're relying on an expiry date. But they do state that the fact that the expiry date is there, than it not being present, makes it at least viable in the sense that it has been, they understand the urgency in which it has been created. They understand the fact that there's a lack of this monopoly in the production of a VVM, and they understand the fact that there's a need to actually self-protect ourselves to certain that we have COVID-free future, I'd say so. So the hesitancy levels though are still present, but adoption levels are also increasing, because I do trust that some people have been waiting to actually see how it's affecting others. So in the belief that a healthcare worker probably was immunized like 2 months ago, they're well right now, they feel better, they haven't got COVID, and then now you're getting immunized now because you trust that the vaccine they got is the same vaccine you're getting, despite it not having a vaccine vial monitor. I'll hand over to Brenda or Casildah to take on from the Zambian perspective. Thank you.
Thank you, Allela. So in Zambia, we had similar thoughts around the missing VVM as well from the healthcare workers. So out of the 18 healthcare workers that we spoke about, the general thoughts around the rollout of the vaccine, only 5 had received the vaccine. And that indicates just the level of hesitance that the healthcare workers have around the vaccine and even administering it. They say that they do not feel confident administering a vaccine that do not have one of the priority features. For those who have received, they indicated that, just like Allela has mentioned, with the expiry date, it gives them a little bit of some level of confidence to say the vaccine is all right, and then being able to discard it also after a certain number of hours. Over to you, Allela.
So maybe just to add, so as we were going around just to get the views around the rollout of the vaccine, so we were with Mrs. Simwenga, who would explain further about the vaccine, and we only hope after our visits there is some increase in the uptake of the vaccine amongst the healthcare workers. Back to you, Allela.
Thank you very much, Brenda. I'll now ask Alex if there's another that I might have missed out on chat. Any other questions?
Sorry, yes. So we have another question. With the multi-dose vials, you mentioned open vial waste in remote settings. Do you have a sense of how many doses are not being used?
Brenda, Casildah, do you want to check on the question on the multi-dose vial?
can Mrs. Simwenga maybe help us from the Zambian perspective?
Should I repeat the question?
Sure, Alex.
Okay, let me repeat the question then. With the multi-dose vials, you mentioned open vial waste in remote settings. Do you have a sense of how many doses are not being used?
Okay, so I'll answer on our perspective. So I talked to a couple of healthcare workers who told me that the vials are coming. It's stated on the vial that it allocates for 10 doses, but they tend to realize that they can actually immunize 12 people because of the residue that remains after they finish the 10 doses. So I will say that a number of healthcare workers are actually providing 12 than the stated 10 because of that quantity that is remaining on a vial.
Hi. So from the Zambian perspective, we wouldn't really say the actual number of, or the approximate number of doses that are being wasted. But from the discussions, we learned that maybe in the 6 hours, they would only receive maybe 2 to 3 clients. That means the rest would be wasted. We haven't really compared like the actual number of doses that a healthcare worker would waste on a particular day. Over.
Thank you. And just to add on what Casildah's mentioned, facilities in Kenya are choosing to only offer vaccines when they meet the maximum, like the stated number. For example, if it's stated 10, they tend to batch clients. So you're booked on a particular day to come for the vaccine, and they'll book it on an hourly basis to actually reduce cost, to actually reduce waste, knowing that there's need for the vaccine. So you're willing to want to actually waste even one jab. Yeah. Over to you, Alex. Any other question?
Yes, I think there's another one. With the change in manufacturers, seeing Kenya having another approved, how are they providing updates?
Brian, kindly answer that. Thank you.
Well, that was a tough one for me. I think I may very well even have to come back to you all on that one. From what we've been seeing, and it's the next manufacturer is yet to be actually deployed. Some have arrived in certain healthcare settings. As far as the Sputnik was here earlier, so that was actually sort of a case by case by the different locations, and so but it wasn't sort of something that the National Vaccine Program had rolled out and was part of their sort of individual training. So back over to you.
Thank you, Brad, for that answer. Alex, any other?
No, I don't see any other questions. I see a comment from, I think, Time, but that's a comment saying that that's a comment saying that they can provide sufficient VVMs for all copied vaccines to LMICs. I would like to ask participants if you have a last question or if you have a last comment. This is your last chance before we close the webinar. No? Okay. So it seems we don't have any question anymore. Allela, I'll let you close perhaps the webinar. Let me know, yeah, if you have a final word to say.
Oh, just the last word I'd love to say is just to thank all the presenters on this particular webinar, as well as everybody who was in attendance. A big thank you to you. And I do hope that we both gain something from these conversations. And we do look forward to more conversations around the Living Labs work and even just listening on also your works. And also thank you for this particular comment on Temptime. We'll actually just think about it and have discussions on it. Over to you, Alex. You can close over. Thank you.
Thank you very much, Allela. Thank you very much, everybody. That was a very interesting presentation. Everybody, we're going to share the recording of this video in case you want to watch it again or in case you want to share it with colleagues. So I'll send you the recording, the link to the recording as well as the link to the presentation by email. Thank you very much again for your interest. And we look forward to seeing you again to our next webinar. Thank you very much to the Living Lab Path team. And I wish you all a very pleasant day. Bye-bye.
Bye-bye. Thank you.
Thank you.